Hello everybody and welcome to Pathologic. Today we're going to be discussing hyperadrenocorticism in veterinary species. Hyperadrenocorticism is also referred to as Cushing syndrome. It results from either pituitary lesions or adrenal cortex lesions. However, pituitary lesions are most common. This condition is most common in middle-aged and older dogs, but it is also occasionally seen in cats. Affected animals may develop concurrent diabetes mellitus. Common clinical signs of hyperadrenocorticism include polyuria and polydipsia, polyphagia with weight loss, a pot-bellied appearance with muscle weakness, and alopecia. There are also skin conditions like calcinosis cutis in dogs and fragile skin syndrome in cats. First, we will look at normal cortisol release to better understand hyperadrenocorticism. The hypothalamus releases corticotropin-releasing hormone, which acts on the anterior pituitary. The anterior pituitary then secretes adrenocorticotrophic hormone, which acts on the adrenal cortex. In response, the adrenal cortex releases cortisol. Elevated cortisol provides negative feedback on the release of CRH and ACTH, thus modulating cortisol release. Now we will take a look at pituitary-dependent disease. This form of hyperadrenocorticism results from a pituitary adenoma that is functional. The functional tumor cells produce excessive ACTH, which then goes and stimulates both adrenal glands to produce excessive cortisol. This results in hyperplasia or enlargement of the adrenal cortex on both adrenal glands. So to start, the pituitary adenoma produces a large amount of ACTH. That ACTH heavily stimulates both adrenal glands, resulting in hyperplasia or thickening of the adrenal cortex on both glands. Next, we will look at adrenal-dependent hyperadrenocorticism. This condition results from an adrenal tumor affecting one adrenal gland. The functional tumor produces excessive cortisol. In response, the contralateral adrenal cortex atrophies as there is no longer a stimulus for it to produce cortisol. So as mentioned, the adrenocortical tumor produces a large amount of cortisol. Cortisol provides negative feedback to the hypothalamus and the pituitary. This inhibits CRH and ACTH release. Therefore, the opposing adrenal gland does not receive any stimulus to continue producing cortisol. This leads to disuse atrophy of that adrenal cortex. Now we will look at some of the consequences of hyperadrenocorticism. Polyphagia, or increased appetite, results from increased circulating cortisol. This is because cortisol can directly stimulate increased appetite and intake of food. In animals with pituitary adenomas, expansion of the tumor dorsally may also contribute to polyphagia, as it can expand and compress the parts of the hypothalamus that control hunger. Animals with hyperadrenocorticism often have muscle wasting, as cortisol stimulates muscle protein breakdown. We see this clinically as muscle atrophy and weakness. The muscle atrophy often results in a pot-bellied appearance, as the animal loses its abdominal muscle tone. As mentioned at the beginning of the lecture, hyperadrenocorticism can also lead to diabetes mellitus. This is because high cortisol levels induce insulin resistance in the tissues. Consequently, glucose is not taken up by the cells and remains in the bloodstream, causing a hyperglycemia. Hyperadrenocorticism can also cause hepatomegaly due to a combination of fat and glycogen deposition. Of these, glycogen deposition is most significant. The enlarged liver can also contribute to the pot-bellied appearance of the abdomen. Steroid-induced hepatopathy is the glycogen component of hepatomegaly from hyperadrenocorticism. This results from the cortisol-induced insulin resistance, which causes hyperglycemia. In response to the hyperglycemia, the liver begins glycogenesis to store that excess glucose. This results in glycogen deposition within the liver cells. Hepatic lipidosis can also develop with hyperadrenocorticism because cortisol induces lipolysis of fat sources. This results in release of fatty acids into the bloodstream. Those fatty acids can overwhelm liver processing pathways, resulting in fat deposition within the hepatocytes, thus causing hepatic lipidosis. Polyuria and polydipsia is another common outcome from hyperadrenocorticism. This is because cortisol can inhibit antidiuretic hormone in the kidneys, which normally stimulates reabsorption of water from the urine. This results in production of large amounts of urine, thus causing polyuria. The increased fluid output results in dehydration, which then stimulates polydipsia. If the animal is diabetic, the polyuria and polydipsia can actually get worse. This is because the kidneys filter the excess glucose into the urine for excretion. Glucose within the urine is osmotic and therefore pulls more fluid into the urine, making the polyuria worse than it would have been with just hyperadrenocorticism alone. Alopecia is also common in Cushing's patients. Cortisol can force hairs to prematurely enter the telogen or resting phase of the hair cycle. Hairs in the resting phase may be shed, but there is little regrowth of lost hairs due to inhibition by cortisol. This ultimately results in alopecia over time. Skin fragility syndrome can occur in cats with hyperadrenocorticism. This occurs due to elevated cortisol causing collagen and elastin atrophy within the skin, making the skin very thin and weak. This ultimately results in spontaneous skin tears. Cats presenting with this condition often have a history that is something like, the owner picked the cat up and its skin tore off. So you can think about that horrifying thought when you think about hyperadrenocortic cats. The abnormal collagen from hyperadrenocorticism can also cause tendon rupture or injury. This most commonly affects the calcaneal tendon in the hind limbs of dogs. Calcinosis cutis is another skin condition that can occur, primarily affecting dogs with chronic hyperadrenocorticism. This condition results from mineral deposition along the atrophied collagen and elastin fibers within the skin. Clinically, we see this as irregular deposits of mineral within the skin tissue. Finally, the mineralization that we see associated with calcinosis cutis can also affect other organs. It primarily affects the lungs, resulting in pulmonary mineralization. The mineral deposits here are likely due to protein catabolism from the elevated cortisol, altering the molecular structure of that tissue and producing an organic matrix that more easily binds to calcium. This mineralization can have a significant impact on organ function, such as causing dyspnea in patients that do have pulmonary mineralization. Now we will look at the diagnosis of this condition relative to how the condition actually occurs. So for diagnosing hyperadrenocorticism, we use dexamethasone tests to either diagnose or screen for the disease. Dexamethasone is used because it inhibits the release of ACTH from the pituitary gland, and therefore it should reduce the production of cortisol in a normal animal. So to perform the test, you administer dexamethasone and then measure blood cortisol levels at 4 hours and 8 hours after administration. There are two main dexamethasone tests that we use, and they are low-dose and high-dose testing. So just to review before we talk about the two different tests, here's how the dexamethasone test works. Giving dexamethasone inhibits the release of ACTH. In a normal animal, this would prevent the release of cortisol based on the pathway that we discussed earlier. Now we'll take a look at the low-dose test. This is a screening test used to identify whether or not the animal has hyperadrenocorticism. In this test, you give a small amount of dexamethasone to see if the cortisol levels respond. If there is a response, cortisol will be low at both 4 and 8 hours, indicating that the animal is responding normally and does not have hyperadrenocorticism. If there is a partial response, you will see low cortisol at 4 hours, but high cortisol at 8 hours, and likely this reflects pituitary-dependent disease. Finally, a high cortisol level across the board indicates hyperadrenocorticism, but you can't determine whether it's from adrenal or pituitary origin. Let's go into the last two parts of that table in a bit more detail. So for pituitary-dependent hyperadrenocorticism, the pituitary adenoma may or may not respond to the low dose of dexamethasone. If it does respond, then cortisol levels are going to go down because ACTH will not be released. If the adenoma does not respond to the dexamethasone, then ACTH will continue to be produced and cortisol levels may not drop at all. For adrenal-dependent hyperadrenocorticism, the adrenal adenoma is going to continue producing cortisol regardless of how much ACTH is produced. So when we introduce dexamethasone, which drops ACTH production, cortisol levels stay consistently high because the adenoma does not actually care about ACTH levels. The high-dose dexamethasone test is a differentiating test that can help us determine whether the hyperadrenocorticism is pituitary or adrenal dependent. Larger amounts of dexamethasone are more likely to suppress a pituitary adenoma, thus causing cortisol suppression. So for pituitary-dependent disease, we would see a low cortisol at 4 hours with a rapid return in cortisol levels by 8 hours. For adrenal disease, the adrenal adenoma continues to produce cortisol regardless of the dexamethasone levels, as we previously discussed, so it still will show a high cortisol at 4 and 8 hours. So to summarize, hyperadrenocorticism is a common disease of older dogs. It primarily occurs due to pituitary adenomas that increase secretion of ACTH. Consequences of this disease include muscle wasting, polyphagia, PUPD, and glycogen and lipid deposition in the liver. The low-dose dexamethasone test helps identify hyperadrenocorticism, while the high-dose test helps differentiate which type of disease is present. Thank you for watching PathoLogic. If you enjoyed this video, remember to like, subscribe, and to share with your classmates. Thanks again for watching, and we will see you in the next video.